So it's my pleasure now to introduce Dr. Tavares. Dr. Tavares is the Senior Director of Programs at the Alzheimer's Association, New York City chapter. She's been faculty at Boston University School of Medicine and Hunter College. Dr. Tavares received a Bachelor of Science and double majored in Biology and History at Tufts University before going on to receive her Doctorate of Medicine at Boston University and her Master's of Public Health at the Harvard School of Public Health. She's been a consultant for a variety of nonprofit and government organizations, applying her expertise in population health and healthcare delivery to improve care to vulnerable communities, and has overseen multiple public health initiatives around New York City. In addition, we are very happy to be their partner here today, and we have an ongoing partnership with Dr. Tavares, and I'm very much looking forward to hearing what you have to say. Thank you very much.
Good afternoon. I'm very pleased to be here today to talk about our work at the Alzheimer's Association to drive the research agenda globally. And thank you again for this invitation and the partnership from the organizations that we heard from that partnered together to make this event a possibility. So with my time today, I'm going to talk about the landscape of Alzheimer's and dementia science and where we're making progress, how the Alzheimer's Association is moving the needle with research, how biomarkers are changing the game, and I'm just going to briefly talk about that overview, and some of the latest advances in clinical trials, treatments, and lifestyle interventions to echo some of the things that we heard from the doctor who spoke previously. And I know that colleagues from NYU, Dr. Wisniewski and Dr. Middleman will elaborate in terms of their areas of research as well. So before I advance, I want to make sure that we're all on the same page in terms of terminology. Many times we use the terms dementia and Alzheimer's disease interchangeably. So dementia is an umbrella term that's used to describe a range of symptoms that cause memory, thinking, or behavior changes. And again, it's a collection of symptoms, and there are more than 100 different diseases that can result in these symptoms. And so that causes an underlying biological change in the brain. And as I mentioned, there's more than 100 different diseases that can do that. Alzheimer's disease is the most common form, responsible for 60 to 80% of dementias. We can also see vascular disease that also results in dementia as well. We also see that there's co-occurring underlying disease processes that can result in a mixed dementia. So for example, an Alzheimer's disease at the same time as a vascular disease. It is for that reason that it's very important that if somebody has any memory, thinking, or behavior changes, they bring this to the attention of their doctor so the doctor can do a full clinical evaluation, identify the underlying disease etiology, and then come up with the appropriate treatment. So we have learned a lot about the symptoms of, that was quicker than I expected in terms of animation. So we've learned a lot about the symptoms of cognitive impairment. What we know is that you start cognitively unimpaired. Then if somebody is going to progress, they're going to move first into mild cognitive impairment, or MCI, so the person can say, something is not right. They may perform relatively well on cognitive exams, and despite having cognitive impairments, those impairments won't interfere with activities of daily living. We know that MCI is a risk factor for dementia and that you need to go through mild cognitive impairment before you progress to dementia. And so that's particularly important because we know that MCI is a risk factor for dementia, and everyone who experiences dementia first passes through mild cognitive impairment. And so this is incredibly important from an intervention perspective because if we can prevent new cases of MCI, we can prevent new cases of dementia. So before I go further, I want to make sure that we're also all clear on the way that Alzheimer's is diagnosed because Alzheimer's disease is the most common cause of dementia. So we know that there's an underlying process, and the science to date has told us that there's a buildup of beta amyloid, which is a type of protein in the neuronal cells that accumulate outside of the cells, interfere with cell function, and can cause cell death. You can also have another process with a buildup of another protein called tau, which builds up, forms neurofibrillary tangles, also interferes with the ability of the cell to transport nutrients and toxins, and also resulting in cell death as well. And this accumulated cell death results in neurodegeneration. And so we can see that in terms of histopathology on gross section. So you're seeing that. Where is the, oh, wrong direction. On the right. So to be called Alzheimer's disease, there needs to be this underlying biological changes in the tissue. So the buildup of beta amyloid, the tau, and the neurodegeneration. And prior to this modern promising period of Alzheimer's disease science, this was a diagnosis that was made post-mortem. And so we're in this new stage where we're diagnosing living people, and our advances in the sciences are making that possible. So at the same time that we know more about the diagnosis of Alzheimer's disease, we also know about what are the factors that put people at risk for Alzheimer's disease. One key point is that even though age is one of the most important risk factors, Alzheimer's is not a typical part of aging. We also know of additional risk factors like family history and genetics that importantly increase somebody's risk of developing Alzheimer's disease, but these aren't things that we can really change, and rather we can focus on some of the lifestyle risk factors like cardiovascular disease in terms of hypertension, diet, diabetes and smoking, as well as social and cognitive stimulation, because those are things that we can actually intervene and make a difference. So currently, there are no therapies that can cure Alzheimer's disease. We have drugs that temporarily improve symptoms, but we are still hopeful because of what we know about the treatments that are available currently. So this chart on the left is showing the different types of treatments and how they act. And what we're looking for in that blue area is a disease-modifying treatment, which we don't currently have. The treatments that we have right now on the market are symptomatic in benefit, and what they do is they work to affect the neurons that are currently sick. And so what we're looking in terms of a real blockbuster medication would be a medication that prevented neurons from being sick in the first place. And that's the real difference between a disease-modifying drug that would stop the progression of this disease and the treatments we currently have available. This is so important because we have 5.8 million Americans in the United States with Alzheimer's disease, and that number is projected to climb to 14 million. We have more than 16 million Americans currently with, who are providing unpaid care to somebody with Alzheimer's disease. It's the 6th leading cause of death in the United States. And it's the most expensive disease in the United States, where the current costs make it the most expensive disease with 290 billion people, and those costs are expected to increase to more than $1 trillion by 2050. And that will, in fact, happen unless we intervene. And so at the Alzheimer's Association, we're working to change that future. So the way we're doing that is by increasing awareness of the disease at all levels of the society so that we can mobilize people to change the future statistics and those pretty grim statistics that I mentioned to you. So one of the key ways that we've been doing that as the Alzheimer's Association is working intensely to create a public dialogue about Alzheimer's disease and the needed research. We do that by bringing advocates from all across the country. They're normal people like you who we go to speak with elected officials. And so what we've been able to do is have some really unprecedented momentum in terms of research funding at the federal level because of that advocacy. In 2011, the funding was $448 million. To today, it's $2.3 billion going to Alzheimer's research, and that's more than quadrupling the budget in a few years. And so what is that translating to? That's allowing for more scientists to be looking at areas of promising research. That means more labs, more scientific instruments, more students that they can hire to investigate these groundbreaking ideas in Alzheimer's research. At the same time that we've been advocating for Alzheimer's research funding at the federal level, we've been also investing globally in research. More than $165 million in 450 best-in-class projects across the world in more than 25 countries. So as an organization, the Alzheimer's Association is directly funding scientists all across the globe. We realize that Alzheimer's disease does not discriminate and doesn't recognize national boundaries. And so we're investing in the scientists who have some of the best ideas because we know that they can come from anywhere in the world. We also advance our research agenda through the power of volunteer scientists, researchers, and medical doctors all across the world. Now, many people know that the Alzheimer's Association, in terms of our advocacy work, our awareness-raising work, is volunteer-powered, but we are also volunteer-powered in terms of our research endeavor. We have more than 10,000 volunteers all across the country and world who work with us in terms of our research agenda, more than 6,000 reviewers in 52 countries. And those reviewers are experts in their field. So for instance, if we're looking and talking about genetics, we're getting the leaders and the best minds in genetics to look at research proposals and decide which of those need to be funded. They're also suggesting to us, well, where are the gaps in research in funding? And we're, based on that expert consensus, deciding where to invest resources. In addition, we have more than 4,000 iStart members all across the world, and so this is a professional society, the International Society to Advance Alzheimer's Research and Treatment, and this is a way to facilitate collaborative conversations and get scientists out of silos and really discussing what will it take to move the needle forward. So these scientists organize themselves in professional interest areas that meet monthly to really see how we can move the needle forward. And then we also have 480 or more work group volunteers in more than 25 countries. To give you an example of what they may do, we recently convened a biomarker work group, and it brought together leading scientific experts in government, industry, and academia to see how we could organize our thinking and our investments around biomarkers. So all our research priorities inform the structure of our grant program and our global collaborative partners. So these 4 pillars of discovery science, early detection, treatment, and prevention are the architecture that undergird who we convene, what we fund, and who we bring to the table. And so this also flows into a really robust medical science portfolio. Things like publications, guideline standards, convening, intramural research, partnerships, funding, and research community engagement, which is why I'm here today. So to give you an example of some of those, in terms of publications, the Alzheimer's Association has one of the most impactful scientific journals in the world, Alzheimer's and Dementia, and so publication is the currency of scientists. This is how they report on their promising avenues of inquiry, and other scientists learn from that and build on that connective knowledge, and that's what really gets us to the next level. In terms of guideline standards, the Alzheimer's Association has been involved in most of the guideline standards that have been published in the last 20 years. To give you an example, the National Institutes of Aging and Alzheimer's Association clinical guidelines on the diagnosis of Alzheimer's. Additionally, guidelines for the use of biomarkers in research. These are other ways that we're driving the research agenda forward. In terms of convening, we have the Alzheimer's Association International Conference. So that's bringing together the leading minds in Alzheimer's research from all across the globe. We convened that last summer in Chicago, about 6,000 scientists. And so they were presenting on their work and on their findings, having a very robust discussion on how we move the research forward, whether it's in diagnostics, genetics, new tools to follow the progression of disease. And I talked to you about our research funding and our partnerships, and I'll talk more to you about our intramural research, and those are studies that the Alzheimer's Association is not only funding, but running to learn more about how we prevent and detect Alzheimer's disease. So we have great investments in the New York City community as well. We've played a significant role in all the advances we've seen in Alzheimer's research, but we've also been directly investing into scientists all across New York City. We have $7.5 million that's active in more than 40 projects, funding researchers at NYU and Dr. Wisniewski's group at SUNY Downstate, Columbia, Mount Sinai. We have very active volunteer reviewers, more than 241, doing more than 2,600 critiques, as well as very active iStart membership. And so not only are we supporting the researchers, but we're also supporting this development of knowledge. And one of those areas is in terms of biomarkers. So biomarkers are incredibly exciting field of research and are really opening new avenues of investigation that will get us to a cure, more effective ways of diagnosing and treating Alzheimer's disease. So many times people don't understand what biomarkers are. So to give you an example of a biomarker, you can go to your doctor right now. They take your blood and they can take your cholesterol. So cholesterol is an example of a biomarker. It gives you a sense of the underlying biological health of your heart. And so Many years ago, we didn't have that biomarker for cholesterol. It required research, and research that was driven by trying to understand how to prevent heart attacks. In the same way, we're trying to develop biomarkers and have developed biomarkers for Alzheimer's disease. And these biomarkers are really changing the game and opening a new, very hopeful window of how we might intervene in Alzheimer's disease. So some of the first biomarkers that have been developed are in beta amyloid. So we're now at a point in the research that we have a tracer for beta amyloid that can be injected into somebody, and through PET scanning, areas of the brain where there's beta amyloid deposition light up. And so those markers and that imaging allows us to understand the progression of disease while somebody is alive. We're also making progress in tau biomarkers as well. And then we have emerging biomarkers in blood and cerebral spinal fluid that are giving us a sense of how they might relate to cognition and disease progression. And we have even more cutting-edge biomarkers in saliva biofluid and optical evaluation. So many people are not aware of the fact that the eye and the retina is actually a part of the central nervous system. And through eye exam, you can actually observe the retina, the vasculature, and also observe buildup of beta amyloid. So it's a window into the central nervous system. So currently, we don't know how predictive these emerging biomarkers, some of the latter ones that I mentioned, will be, but they could be a tool in the future to help us with diagnose. And our big picture goal here is to try to get less invasive diagnostic tools that could help doctors and scientists more easily diagnose Alzheimer's disease, track the disease over time, and really we're looking for diagnostics that could be scalable, that we could bring to the bedside, to the clinical office, not only across the United States, but also the world. So many times, people do not understand that really biology is driving behavior. So people with Alzheimer's disease don't choose to not be able to learn information. They don't choose to not be able to recognize their loved ones. This is the result of underlying biological processes in terms of buildup of beta amyloid, these tau tangles, and brain cell death. And so the more we are learning about this process, the more that we can intervene. And so learning about these biomarkers is allowing us to modernize the diagnosis of Alzheimer's disease. So we're learning that the presence of beta amyloid, of tau, and this neuronal degeneration happens 20 years before the clinical symptoms actually arise. So this is providing an incredible window for us to intervene in terms of therapeutic targets and prevention. So where are we in terms of progress towards developing more effective treatment? So there's a lot of interesting information and progresses that is being made. And first, a lot of the discussion is always in terms of a drug. The United States loves a pill and loves a silver bullet. And so we've heard a lot in the news about anti-amyloid trials. You may have heard last summer about BAN 2401, which was one investigational drug that was found to improve clearance of amyloid plaques and also suggested improvement of cognition. So this medication needs phase 3 trials to proceed. And You've also probably heard in the news in terms of aducanumab that seem to have incredible promise, but recent information shows us that it's not as promising. But the reason it is still a very hopeful picture is because these are all active areas of scientific inquiry right now. So we know of many different therapeutic mechanisms for how Alzheimer's disease progresses, and these are all active therapeutic lines of inquiry that are under investigation at this moment. These are areas of research that are being funded by the National Institutes of Health as well as the Alzheimer's Association. So we know that immunity and inflammation play a great role in Alzheimer's disease, so scientists are working on that. We know that how brain cells metabolize nutrients as well as clear toxins is important in the development of Alzheimer's disease, and there's ongoing research on that as well. Even research on sleep and circadian rhythms and how that influences health. So these are all promising avenues that scientists are looking at, and we don't know which of these promising avenues will actually lead to the next therapeutic. But because there's so many lines of inquiry and so many bright minds on this is why this is a very hopeful picture. In addition, we also have research that's focused on the non-cognitive symptoms of dementia. A lot of times we talk about memory, thinking, executive planning ability, but there are also non-cognitive symptoms like behavioral and psychological symptoms that are very distressing for families and are major impact on quality of life. And so there's currently studies right this moment that are really focused on agitation and sleep disturbances and getting at a pharmaceutical intervention that would help, as well as supportive interventions targeted at caregivers that you're going to hear from Dr. Middleman about. So where are we in terms of lifestyle interventions? So many of you may have heard of this study, which is a Sprint Mind study. Has anybody heard of that by a show of hands? Okay, only a few, but still great that a few of you have heard about this. So this was the first study of its kind to demonstrate reduction of new cases of cognitive impairment. So this Sprint Mind study was conducted in 9,000 people over age 50 who were at increased risk for developing cognitive impairment. And they separated them into two separate groups. One group getting standard blood pressure control and another getting intensive blood pressure control. And the targets for the standard group was to keep their blood pressure to 140, the systolic number. So that's the top number in your blood pressure. And in the intensive group, to keep their blood pressure to 120. And the findings were that in the intensive group, the risk of mild cognitive impairment was reduced by 19%, which is huge. That's 1 out of 5 people that reduced their risk for MCI. And then 17% reduced risk for dementia. Now that dementia risk wasn't statistically significant, which is why the Alzheimer's Association is investing in a continuation of this study, the Sprint Mind 2 study, to follow this intensive group over time to see if a longer period of intensive blood pressure control can lead to that reduced dementia risk. In addition, the study looked at the MRIs of the intensive group compared to the MRIs of the standard group and found a dramatic reduction of small vessel disease in the intensive group. And so that's pointing very clearly that lifestyle modification can really change the underlying disease in the brain. And that's another reason why this is an incredibly promising study. So why is this important? It's telling us very clearly that there are things that we can do right now to reduce our risk of MCI and dementia, especially regarding cardiovascular risk factors, that heart health is really brain health. Because right now we have medications to deal with hypertension. As we've heard, we know about prescriptive diets that are helpful in terms of heart, that are also helpful in terms of brain health. And so this has immediate life-changing impact potential if we can harness what we're learning right now. And so the Alzheimer's Association is working on how do we get that best recipe for lifestyle intervention that results in a reduced risk of mild cognitive impairment and dementia. And so we're pioneering and leading a landmark study called the U.S. Pointer Study, which stands for U.S. Study to Protect Brain Health Through Lifestyle Intervention to Reduce Risk. This is a 2-year multi-center randomized clinical trial comparing two groups of people, a group that gets a self-guided lifestyle intervention versus a more structured one. And so in that structured intervention will be self-management of cardiovascular risk factors, nutrition counseling, diet, and an intervention of social and cognitive stimulation. And the reason we even thought that this study would work in the first place is from what we've learned about the FINGER trial. So that's the Finnish Geriatric trial, which found that similar multi-component intervention in terms of diet, exercise, lifestyle, and social and cognitive stimulation resulted in decreased risk of cognitive impairment. But we know that the Finnish situation is very different than the US situation. In Finland, they're very homogenous in terms of ethnicity, diet, exercise. Also, they have a socialized medical system as well as a very strong educational system that makes it very different from the US situation. And so we want to test this recipe in the diversity of the United States. At the same time, the Alzheimer's Association is drawing and leading a worldwide consortium to get to this best recipe of lifestyle interventions that can prevent mild cognitive impairment. So those are currently being run in the UK, China, Australia, Singapore, and then we're also bringing on other scientists across the world to study in their environments what is that best recipe of lifestyle intervention. So I hope that you've taken away not only what the Alzheimer's Association is doing to advance the needle in terms of Alzheimer's and dementia science, but also why this is a really exciting time in research. We have, like never before, new tools for detection and diagnosis. There's a growing diversity of therapies that are currently under investigation. And we have this new body of research that's adding credibility that could get us to a point where we have a future therapy that combines drugs and modifiable risk factor interventions. And for all of that reason, that's why there's hope in research. Thank you.
PET imaging?
So currently PET scanning is investigational, meaning it's something that you can get as part of a research study. You can pay for it out of pocket. If you wanted to get it for free, one way would be being part of a research study. In addition, the Alzheimer's Association is working on a larger study called the IDEA study, which is focused on using PET scanning in situations where doctors are unsure of the diagnosis. And so the hope is, as a result of this study, that the Center for Medicaid and Medicare Services would change what they cover, but we're several years away from that. So right now, the only way to get PET scanning is either paying out of pocket yourself or participating in research trials, but we are very hopeful that based on the research that's emerging from that IDEA study, we will get to a point, hopefully several years hence, that CMS might change what they in fact cover so that PET scanning could be available to many more people.
I went to, I guess it was Alzheimer's doctors, and they were presenting in Jersey, and they were at that point telling us the exciting research where they were doing what you mentioned, the saliva, and it was up in Boston. And so that's like 3 years out now. So is there anything that came from that, from the Alzheimer's Association?
So it was a...
They presented that that's what they were really, the Alzheimer's Association was actually really into. In Boston, they were doing these studies where they were doing saliva swabs.
So
that's 3 years ago. So that's what I'm saying. What was gleaned from that?
So I'm not sure what particular person you may be referring to, but generally, as I mentioned, these biomarkers are giving us more information in terms of how we might track progression of Alzheimer's disease, how we might identify people who are, 20 years, 10 years before actually showing clinical symptoms. So as many of the things I described, they're still in the research stages, and so we're learning more and more every day about how that harmonizes with clinical symptoms. So we're not there yet, but there's a lot of promising research. And so basically you need to match up what you're finding in terms of biomarkers with clinical development, and then other scientists need to confirm your research findings, because that's how the research world works. But there's a lot of promising research.
Hello. I seem to be near someone's phone. I'm a Brooklynite and a caregiver, and I'm of a very dear friend and very early stages, very articulate person, and I'm wondering what are the advantages of being in a research study, and what are the steps that one could take if one lives 15 minutes away by taxi or, car from this very place where I understand research is being done.
Absolutely. Thank you for your question. So I think in terms of advantages of research, there's one, that altruistic motive in terms of contributing to the body of knowledge, potentially being able to partake of cutting-edge medications or research. So I think there's that great altruistic benefit, being able to use diagnostic technologies like PET scanning. So there's some great advantages there. And so how might you go about it? There's many different ways that you might be able to do so. One of the ways, we do have Trial Match that connects researchers and potential study subjects to scientists who are currently working on research projects that are promising. So you can reach that through the Alzheimer's Association, but there are also different agencies that have their own clinical trial matching services. We also know that our colleagues at SUNY Downstate also keep their own repository of research studies and can connect interested parties to the scientists who are conducting that research. So those are a few of the different ways that you can be connected to research. Does that answer your question?
I think we have time for one last question.
It's not a question. I just want to address the previous question about where you can find what happened with a particular study. If you go on PubMed.gov, and look up one of the principal investigators' names, you might be able to find out what happened to a study you were following.
Good afternoon. I'm a caregiver, and my mom was recently diagnosed with dementia. But the thing about it is she's the only person in my family that's been diagnosed with it. Is that unusual?
No, that's not unusual. Many times people hear, oh yes, there's a family history or there's a genetic component to Alzheimer's disease, but there are many people just like you who don't have any family members who've been diagnosed. And so in many cases, we see people who don't have a family history. That's why it's so important for us to educate and raise awareness of the disease and what the warning signs are, so that people know very clearly when they see those warning signs to go see a doctor, so that they can actually intervene in terms of what's happening.
Hi, good afternoon. I recently received an email request for us to encourage our political representatives to look into the research of Alzheimer's prior to 50 years. So I don't know in terms of the research, what age group you're looking into, because I think there is maybe an increase in the amount of people who are experiencing Alzheimer's prior to the age of 50. Could you enlighten me on that, please?
Sure. So in terms of who sent that letter, I'm not so clear about, but the question behind that is early onset Alzheimer's disease, and that's Alzheimer's disease that occurs in people before age 65. It's about 200,000 people in the country who have early onset Alzheimer's disease. And that's one of the key areas that we are funding at the Alzheimer's Association. Currently have a study called the LEAD study, which is really looking at this group of people, trying to understand what's different in terms of their disease progression, following them over time with imaging, collecting saliva samples, genetics, understanding more about this population to see if it's different from the people who develop Alzheimer's after age 65. So there's a lot of promising research, and the thought is that by learning about the differences, we'll be getting that closer to treatment as well as more effective ways of diagnosing, because we found from other diseases that has been very helpful to tease out the differences between groups that are more severely affected versus those that are affected later in life, and understanding what's the difference between those two has led us in certainly cardiovascular health to medications and other advances. Thank you very much.